well. But essentially, this is a 51-year-old gentleman who has no significant past medical history, a very high-functioning a person at the time of diagnosis. He was first diagnosed with MS in 1994, and the initial onset of symptoms he describes as groin and thigh numbness. He recalls having an MRI at the time that was reportedly typical for MS. We don't have the MRI imaging at the time. He also recalls having 1 to 2 relapses per year, mainly consisting of sensory symptoms in hand and leg that required frequent IV steroid use. He also recalls being on Avonex starting in 1996. He says that on Avonex, he had continued to have the same frequency of relapses, with the worst episode in 2001, where he reports having weakness in both legs and also losing the ability to walk for a short period of time. Given this episode in 2001, he was put on combination therapy with beta-seron and Copaxone. And he also recalls having 1 dose of Novantrone and also pulse steroids at the time.
Hey, could I interrupt Elliot again just for 1 second? Just yeah. Very lovely presentation. If you go back to the very beginning with the distribution of this patient's sensory problem in the groin, and then we have the episodes to follow, and of course the conspicuity of those episodes, we're focusing, just to make sure we're all on the same page, neuroanatomically, where are you most likely to put all of these problems, and having excluded peripheral and other issues.
Right.
Looking back in the history, so which part of the neuraxis is most of the action occurring in, and especially early in a male?
Right. And I would say the spinal cord is probably most likely both either the cervical or thoracic regions.
Right. So if anybody is looking down and thinking, remember we had our first FDA approved drug in '93 with beta-seron, and you can see how things advanced, and eventually you're hearing about pulse steroids and Novantrone. So clearly the managing team, like I would hope all of us would be, was very preoccupied with the location, which real estate matters. There are gender issue differences in MS, of course. And interestingly, here's an interferon Copaxone combination, not like the CombiRx trial, but similar sort of idea and thrust in terms of one from column A and one from column B. So with that being said, just one more pearl, and that is anybody who's received Novantrone, much less commonly used now, although it is approved by the FDA for MS for certain criteria, that if the patient gets Novantrone, we have to not forget that we can see delayed manifestations or adverse events. 2 things we worry about is leukemia, acute promyelocytic leukemia, and the second issue, of course, is vacuolar cardiomyopathy. So the recommendations have changed over the years from an ejection fraction of at least 50%, but subsequently after even a single dose of this drug, which is in that family of anthracene diones like adriamycin and doxorubicin, those patients really should have an estimated ejection fraction either by MUGA or quantitative echo every year, because we can see delayed changes due to the drug. So I'll stop there. Those are 2 really important pearls, especially for the young colleagues of ours who are on, who may not have used Novantrone, and in fact over time may potentially never use Novantrone. But for those of us who have, and I know Bob has and I have, we had 107 patients treated with Novantrone when we downregulated, and we had 2 patients who developed acute promyelocytic leukemia, no cardiomyopathies at this point. And by the way, those 2 patients survived and did extremely well, but you have to be on guard. Just like with Lemtrada for 4 years, do they develop a secondary autoimmune disease? With this drug, the delay and latency from treatment to the onset of these adverse events can be quite long. Okay, Yi, thanks.
I once asked at a meeting, ENS meeting, I think it was in Rhodes, and somebody said that they had actually seen a promyelocytic with the 3rd dose after only 3 doses. So, you're right, it can always happen.
Glad you brought that up. In the 2 patients, one was a latency of 4 years after it was 4 doses of 12 milligrams per kilogram, and that was a former president of a major bank. He's fine. The other one is a mother, housewife, raising 3 children, who very similarly actually had this during the course and after the 3rd dose of mitoxantrone, developed APML, or acute promyelocytic leukemia. So I'm glad you brought that up, Bob. This is not just theoretical. It does happen. And we discovered both pathologies on our quarterly routine testing. These patients were subsequently on other things. But when we saw a peripheral characterization of promyelocytes, clearly we knew exactly what we were most likely dealing with. And so it is something to keep in mind. And remember, this also applies to adriamycin, doxorubicin. They are part of the same anthracene-dione class. And I would suggest some of our neurology colleagues who know about this are actually more OCD and focused on this than our colleagues even in cancer, who sort of laugh at us periodically. We use it all the time. But you have to continue surveillance. That's the key. Okay.
So, Leon, it's Scott here. I don't want to slow anything down, but I just want to remind everybody that we approved this drug not recognizing the extent of the APL. In 2000, it was recognized that there was a risk of about 1 in 400 or 0.25%. By 2010, it was recognized it was closer to 1%, at least 4-fold higher than what was originally thought when it was approved.
Boy, great memory. I was in the audience in Paris when Gilles Zidane presented this and specifically mentioned the 0.25% incidence. And Scott, ours and others, I know Mike Racky when he was at Ohio State and others, our experience was about a log higher. It was about 2.5 to 3%. So it's not trivial.
Okay. And just in case, just quick, if you have a patient who's lives in Europe or been in Europe, ask Halfway. They still use it there, especially in France.
Yep.
Hi, this is Ed Fox, and you know, they changed the labeling on this well after it was approved to say that you needed to check a MUGA or echocardiogram every year indefinitely after treatment with this. Initially, it was before each dose, or you know, it was actually the original thought was yearly, but it's very different than it used to be. And I think for anybody who's inheriting a patient, they may not remember that one dose. And so we need to really work on getting medical records and find out whether they ever got it or not, because at that point, we're the ones who are going to be doing the monitoring.
Yep. And, you know, first of all, Ed, welcome back. Ed is part of the editorial and the co-management team and has been away a bit with some personal issues, but it's great to have you back. And that's a very, very important point, Ed. I think where we're most likely to have problems in dropping the ball is not knowing the antecedent history before they get to us.
Right.
Okay, Yi, I'm going to take chair prerogative and quiet myself and everybody else so we can go to the next slide and keep moving. But
right. So basically on this regimen, it seems like he had some difficulty with adherence with the beta-seron and Copaxone. So there was a period of time where he did have more relapses, and he recalls having an active MRI and clinical worsening with left-sided weakness on that regimen, or not on. So because of this, in 2006, he was switched to Tysabri. He was on Tysabri for 7 years, and he recalls this being the best medication for him in terms of disease control. He says he was radiographically stable, and he did not have any clinical relapses on Tysabri. Examination from the time that he was on by a prior neurologist did show only mild left leg weakness at the time, with an EDSS of estimated about 4, but he did complain of some mild gradual progression in both cognition and gait at the time. Ultimately, he did have seroconversion of his JC virus status, and given his prior immunosuppression with that 1 dose of Novantrone, he was considered to be high risk for PML and therefore was switched to Tecfidera in 2013. On Tecfidera, he had continued gait progression, and some of the documentation did suggest that there was involvement in the right leg as well at the time. Mild, with an EDSS estimated to be about 6, and at that time he was using a cane. He developed persistent lymphopenia on Tecfidera. At one point even went to off-label once daily dosing to see if there would be any improvement in that. There was not. And his MRI on Tecfidera in July of 2015, which I'll show you guys, compared to a 2013 MRI, which we don't have, did report to have some mild progression of the brain with 2 new non-enhancing lesions and more prominent and new non-enhancing spinal cord lesions at the time as well.
Hey, Yi, let me make just one point or comment or question to the whole field, and that is, first of all, the presence of JC virus IgG and an elevated index, I just want to be clear about this, is not an exclusive predilection for PML associated with one class of agent or another. I think most of us now recognize that the highest susceptibility class of DMTs and MS for PML still is likely the selective adhesion molecule inhibitors, such as for, of course, Tysabri. We knew a lot about this in terms of psoriasis with Raptiva. We had 4 PML patients in the first 500 treated with that remarkable drug that inhibits LFA1 and ICANN. But my point is the presence of that predilection, and you're thinking about it because of the JCV and an index that's elevated, also applies to the predilection, albeit less, with Tecfidera when the lymphocyte counts and therefore the infectious or antimicrobial handling capacity of our own immune system is compromised because of too few cells. And I think we could make similar comments about Gilenya. If we see it with the Aubagio, we know the cousin is CellCept. We have seen PML not in MS, but in other groups. So I just want to be really clear that many people sort of link together JCV, risk of PML with Tysabri exclusively, and nothing could be further from the truth. The second issue is that there's increasing evidence to suggest now that delayed dosing intervals, and perhaps as long as 8 weeks, which Teresa and I have been doing with our patients since the drug came back to market at Tysabri in June of 2006. At that time, not because of our knowledge of antibody issues, the Stratify study didn't start till later, but because people were having frequent infections. And in our female population, which is 80% of ours, most of that was fungal vaginitis, who hadn't had it for years and then would have it 3 consecutive months with Tysabri. Did we think it was related? We did. And the answer there, and essentially mitigated, if not abolished that risk, was moving from 4 to 8 week dosing. And our group, among others, published together in JNNP our experience across 9 centers, over 1,000 patients. Just in terms of efficacy, it looks very similar. And we haven't really had 8-week PML in people treated with conventional standard 4 versus 8. There are unique patients who have been treated with a hodgepodge of different immunosuppressants or chemotherapeutic agents where we've seen it. But in fact, one of the papers accepted as part of the N2 process here is by David Lapidus, who's David is actually on the line with us tonight. And that was a 6-week latency and was a granule cell cerebellar form of PML. So I just want to be clear, a lot of people were jumping ship from Tysabri, probably most conspicuously to Gilenya. That's now been triggering multiple papers that have shown the Tysabri to Gilenya transformation led to not only recrudescence of MS, but in some cases, not an insignificant proportion, rebound that looked just like Iris. So the take home there is if you're going from a high ground of something as powerful as Tysabri to Gilenya, very good drug, but that transition can be associated with rebound, and a gram of steroids the month before or the month you change is often not sufficient. You may need 3 to 5 days of steroids, perhaps for 2 to 3 months, along with whatever drug you're transitioning to. So I just want to put a plug in for delayed dosing of Tysabri, and we've seen great efficacy there from 4 to 8 weeks. And again, the JC virus positivity and the index also applies to susceptibility to PML with other agents. That's my point. Okay, so Yi, go ahead and continue.
All right. Okay, so in July 2015, there was a discussion between the patient and his prior neurologist in terms of what to do with Tecfidera given his lymphopenia and also associated PML risk as well. And the plan or the decision they made at the time was to transition him to another DMT and discontinue Tecfidera July 2015 and wait for his lymphocyte counts to improve. Unfortunately, he did not get seen until April 2016 due to transition of care. So he was off of DMT treatment for about 9 months until April 2016 when he was seen at the University of Washington MS Center. At the time, he continued to complain of clinical deterioration. He was saying that he was now using a two-hand walker as well as double forearm crutches with bilateral support and power wheelchair for long distances. And that was deterioration for him compared to prior. And on our exam, he didn't have any notable findings in terms of cranial nerves, and his mental status was intact, but he did have mild left upper extremity weakness as well as bilateral lower extremity weakness, more significant on the left, with spasticity noted in his lower extremities, brisk reflexes, and bilateral Babinski signs suggestive of cortical spinal tract involvement, and also a mild left upper extremity dysmetria and clumsy finger tapping on that side, and some sensory loss on that left leg as well. And overall, his gait was wide-based and limited by the left-sided weakness and spasticity that he had.
Do you get the impression that over at least that 1 year period, if not more, that he's actually progressing and not having relapses, at least at the clinical level?
Yeah, at the time, initially, yep.
And the other point, Guy, is that I would really like to make, and it's very important. You know, if you're on Tysabri, not having lesions, attacks, not exhibiting progression, perhaps the big benefit on progression there is saving the patients the lesions and attacks they might have had on a different drug or on no drug, and they progress in that way. Progression is not exclusively limited, of course, to PPMS or secondary progressive or progressive relapsing MS. People progress from attacks they don't recover from. But here's the pearl. If someone is already progressing, and let's say in this case we put him back on Tysabri, it's about 80% of patients will continue to move. If you're already on Tysabri, you exhibit long periods of stabilization, clinically, radiologically, the doc's exam, your home exam, the family's exam, that's great. But if that progressive horse comes out of the barn while you're on Tysabri, the number is essentially the same. 4 out of 5 people will continue to advance in progression. So for me, when that's seen, dovetailing on Bob's question, was there clear evidence that was convincing that this patient is exhibiting progression, but not linked in any way or coupled to attacks, but truly exhibiting secondary progressive disease? Right. That's likely a patient who would be a candidate for other considerations, whether it would be Ocrevus or Lemtrada or one of the other agents, knowing full well we don't have a randomized controlled trial for every one of those in these cases, but we do know patients on the move on Tysabri will continue to exhibit progression at about a rate of 80% of those patients. So we've got to be really, really careful. And the sad thing about this story is, how did this guy actually get lost to follow up without treatment for that period of time? And you know, whether the drug is sufficient to exact remission or not, we know the disease, both the relapsing and the progressive or exclusively or predominantly progressive phase of the disease, is clearly more dynamic in terms of disease activity when people are off the drugs versus when they're on the drugs. So they're not perfect, but they play a role, a very important role. Okay.
Okay, good to know. I wanted to show you guys basically the first MRI that we have in our system, which was from 2015, just to get an idea of his baseline lesion load. Let me see if it'll play on this one. I think this one's better. Okay, so as you can see, and I'll play this again just to get a better idea. Everyone can see the video, okay?
Yeah, it's on and off. And by the way, not only is this fairly classic, but it drives home a very important question. If you could go to one of the, keep going, one of the more rostral scans where you have a large burden keep going. They're all large, but large burden of perpendicular. Here we go. You know, when you ask, oh, how many lesions do I have? Do you see the problem with counting? If you had one little tiny solitary, that's okay. But these, for example, back in the right posterior periatrial or periventricular area, how many is that worth in confluence versus one of the more singletons that's more well circumscribed? You see my point that probably volumetrics is better. If you have a couple lesions that are distinctive, that's easy. But this is very, very hard to quantitate in terms of numbers. And so the idea of having a quantitative MRI report into the future, I know Bob Zabadnov, a number of people have been working on this over the years. This is one of the fundamental challenges. And of course, over years and years, many of these lesions can be incorporated into the atrophy that also continues at the level of the ventricle and third ventricular width. So we've had patients come in years later and say, God, isn't it great though? My lesions are gone. Well, you have to temper that with, well, part of the issue that explains this is that the lesions have actually been swallowed by the ventricle, which is getting bigger because the brain is undergoing accelerated atrophy. Any comment that you have about that, Yi, when you looked at this and talking to the patient about this in terms of, you know, what do you say to a patient with this particular pattern of male, predominantly spinal cord, motor involvement, as part of the preamble to discuss what you're going to recommend and trying to match in terms of a commensurate therapy with a patient who has clinical disease, which is pretty significant, but also fairly abundant and severe radiographic disease?
Yeah, you know, I think that's a good point. And it does seem like he has a good amount of lesions that are present both in his spinal cord and in his brain. And it does seem like over time he has clinically gotten worse. Therefore, I do think being more aggressive and escalating his therapy is a good idea to kind of preserve, you know, the function that he has left. He is, at the time at least, using a walker and power wheelchair for longer distances, but to maintain that level of function was important to him, and you know, that I think that is something to consider as we're talking to him.
Hey, Leora Freeman is on the line with us, who's a spectacular neurologist who has an interest, more than an interest, her research focuses on the imaging aspects of this disease. Leora, could you just make a comment about the clinical radiologic paradox? And I know David Lapidus is on in this recent paper, but sometimes what you see is not always what you get. And maybe you could just make a comment about the fact that that paradox is very well alive and well, unfortunately. And what does it mean? How do we define it? And how does it become of some utility to us who sit in the room one at a time with a patient and look at this evolution versus the patient who may have a very small burden of disease, but can either be silent or could be affected in a devastating way? Any comments, Leora?
Yeah, no, absolutely. First of all, I was, while you were speaking, I was just thinking, I'm going to text you amen, Elliot, for what you said about volumes versus number. I think that this is a very important comment. Also, there's also comments that I wanted to make about this MRI about some kind of diffusely abnormal white matter that we can see, you know, surrounding some of these lesions that may also be pathologically, that are pathologically abnormal and contribute to the burden of disease of this patient. So the clinical radiological paradox really is the concept that you may have patients that have a high level of clinical disability, but a low burden of disease, and vice versa. So we see that every day, I think, in our practice. I remember when I had a patient that had not been in clinic for a while, so I didn't know her, inherited her from Jerry, and I didn't know her, and she came with an MRI, so I saw the MRI before I saw the patient, and she had lesions absolutely everywhere, and really, you know, very little normal appearing brain tissue. And I was really expecting finding somebody, you know, of course I should know better, but, you know, I was expecting seeing someone who was pretty impaired. She had an absolutely normal neurological exam. The opposite is another patient of mine that we've been following for 5 years in our practice. He has one lesion in the brain, he has a couple lesions in the spine, and he has a relentless progression of his neurological disability, you know, that really illustrates that there lesions are just the tip of the iceberg. What we see is not exactly what we get on the pathological level. And
if I could interrupt just for 1 second, Leora, you would also make a comment that perhaps what you see is not only what you get, but the histopathologic heterogeneity of water or proton imaging, which is what this is based on, raises a diversity or a spectrum of pathologies everywhere from demyelination and room for more extracellular water, remyelination, where we may trap water in the concentric rolling, and of course astrogliosis. So your point is really well taken. By the way, the other point is when you say Jerry, in the context of MS on the planet Earth, at least at this point, everybody knows you're talking about Jerry Walensky. But if there's some really young people on to say, like, who's Jerry? Jerry is Jerry Walensky. But probably for a long time to come, when people talking about MS mention Jerry, they know exactly who you're talking about. So.
In relation to this, I wanted to also bring up the recent description of in Bruce Trapp's paper about the cortical. Myelopredominant MS, so spinal cortical, I don't remember how they call it. So basically, in the MS, where pathologically the damage is localized in the cortex and in the spinal cord. But when we look at those patients on MRI, which the MRI was acquired on these tissues, then the MRI showed white matter lesions. Just you would not know that it was a different form of MS from looking at the MRI. But when they looked at those patients pathologically post-mortem, they found that the damage was actually not in the white matter, and there was no myelin damage within these MRI visible lesions, but they were primarily located in the cortex and in the spinal cord. At least that's what I took from it.
With that point, I was going to ask you, Bob, to actually make a comment about throwing away the meninges for 200 years and then putting them back, leaving it. What does Bob Bliss think on this?
So the meninges, I mean, is and the newer techniques that people are using, including Danny Reich, is going to really be helpful because the thickness of the meninges is not like in sarcoid or in cancers where it's really thick, but we know things are going on there. What they found, Bruce said, and in the article, in the white matter, they found changes, but it was more like axonal changes. So, and yet it showed up because of water damage as white matter lesions. But the other thing is that this gentleman has had, from the beginning, everything that you said has been spinal cord symptoms. Mm-hmm. So whether he's been imaged or not, he has a lot of problems down there. And the other thing is, I had one of those happen where I was ready to fire the resident when he presented the normal exam because I'd already seen the MRI scan and it was normal. But just on the one cut that you have here, there are about 4 or 5 black holes.
Mm-hmm.
Bingo.
And that if you look at some of the work out of the Dutch group, that correlates pretty well too, because you've lost oligos, axons, myelin, period. It's gone. So there are people who actually, not to get into too much of a sidetrack, talk about T1 to T2 lesion ratios, or T2 to T1. It depends where you like the numerator and where you like the denominator. And this gentleman has 4 or 5 that I can see just on one cut alone.
Yeah. So my point about histopathologic heterogeneity of demyelination, remyelination, astrogliosis, the one issue that sort of helps in terms of differentiating repair versus more destructive lesions is exactly what you just said, which I think is worth reiterating, and that is there a corresponding presence of low signal on T1? And we know from the Italian and the UK groups that the lower that signal, the darker, the more likely it looks like CSF signaling, the more likely under the microscope you've had tissue deconstruction. And exactly right, loss of oligos, loss of axons, and it's essentially been replaced by water. So very, very important. So Yi, I'm going to take chair's progression and prerogative, and let's go ahead and continue because I know we have another great presentation coming up after yours.
Okay. All right. Sounds good. So I'm going to keep going. Essentially, I wanted to show you what has happened since the time that we saw him initially. He We looked at the MRI from July 2015. He had clinical deterioration for which he was given 2 doses of pulse steroids initially, and then had a clear clinical relapse in July of 2016 with lower extremity weakness, and was given IV steroids at that point. There was a discussion in regards to the next DMT option, and decided to go with rituximab. That was given in July 2016, and he was given 1 gram, 2 doses, 2 weeks apart at the time. And after the second dose, 6 months later, he had another MRI, which I'll show you as well, with 1 new GAD-enhancing lesion, and had another clinical relapse shortly after that in June of 2017. At the time, he had mildly low IgGs. His peripheral CD19 count was 0 throughout the whole course of getting B-cell therapy. And at the time when he had the clinical relapse and the active MRIs and low IgGs in combination with the lymphopenia and some side effects with the steroids from before IVIG was given then. He had another MRI 2 months later, which showed again 2 new enhancing lesions, again another clinical relapse, and this time he got steroids. So I'll point out the 2 MRIs in 2017 after rituximab was given. One is this one here, which you can see this faint enhancing lesion that is I guess half ring or arc-like in this area, and this image is really of his cervical spinal cord. That just wanted to show at least the initial spinal cord burden as much as I can, because it's the best image that we have without too much artifact. And at the time, there was no new spinal cord lesions that were noted compared to the 2015 one, just this 1 new GAD-enhancing lesion. And then in July 2017, and that was 2 months after the previous scan, he also had 2 new gadolinium enhancing lesions that were small here, as you can see.
And Yi, if you look at that image on our left as we're looking at it, if you look further to the left, our left, looking at the image, up the choroid plexus and the posterior atrium of the lateral ventricle, there's an area, if you look very carefully, where there's a little bit of, keep going to your left, a little speckled enhancement. And the question is, keep going left. It's actually juxtacortical. You can see a little bit of low signal around it. Keep going left, and then up. Go up, and then up a little more, and now left from there. Left from there. Right there. So the question is that breach and barrier? Is that artifact? If you look closely at it, to me at least, it looks like that may be the third. I see other issues which are pulsation artifact and others, but I wonder if that's another area. The deeper you look, the more you find.
Yeah.
Just like studies years ago said, if you give double, triple dose of GAD from 0.1 to 0.3, or you have more latency for GAD penetration, the more you optimize, the more you see. But the point you've made is very well taken. There continues to be breach in the integrity of the blood-brain barrier. This person needs more firepower against this process.
Yes. All right. So I'll keep going in terms of his course. So that was July 2017. In August of 2017, after FDA approval of Ocrevus, he was actually given Ocrevus and given his first dose that was split 2 weeks apart. And then the MRI that was done in January 2018 was even worse, with worsening inflammation, and also he had associated clinical relapse at that time as well. And I will show you the MRI for that one.
Hey, could you make one comment about this is a gentleman who at least appeared to be continuing to exhibit activity on Rituxan.
Yeah.
About the rationale, everybody does things differently, and you see various things, but the rationale of going from Rituxan to Ocrevus, obviously one is chimeric, the other one is humanized. I know it's mentioned B-cell drug. It may be targeting a B-cell protein. I know Scott Zamville will like to jump in on this. It's obviously a target against CD20. But, humoral and cellular immune cells and regulatory cells, antigen-presenting cells, they talk to each other. It's like immunologic GPS. So what may start out as a site-selective target against CD20 on B cells ultimately becomes not a B cell drug. It's more pleiotropic because B cells talk to T cells. So, but I'm just wondering about what was the thinking about Rituxan versus Ocrevus, just in terms of have people's experience been that it's more powerful than Rituxan, or with breakthrough on Rituxan, have people done Ocrevus and seen really good, believable, durable stabilization?
So I'm not sure if there was a thought process in switching over to Ocrevus in terms of the mechanism, but rituximab, and I'm going to touch on this just a little later, but basically does work in terms of both antibody-mediated cellular toxicity on top of the cytokine-mediated cellular toxicity against B cells, where ocrelizumab is more humanized and really thought to have more antibody-mediated mechanisms rather than the cytokine-mediated mechanisms.
Somebody might have been afraid to, the other courts of high repeal obviously include the anti-CD52 of alemtuzumab, and there are other approaches as well. But anyway, I know we're short on time, so we'll go from there. But people do lots of different things, and I think it's fruitful to discuss rationale thinking. Yeah.
Before going on the rituximab versus ocrelizumab, remember they're both anti-CD20. They both do the same thing.
That's my point.
By a different mechanism of depletion, where what you pointed out was humanized versus chimeric. That's not so much as the importance. It could be, but really it's the business end on the other end of the molecule, which confers the capability to fix complement or ADCC. So ocrelizumab does it differently. It's a softer touch. It may be deeper in its B-cell depletion, but it's not as acute as a complement-mediated cytotoxicity that caused tumor lysis and death with B-cell lymphoma patients.
Yeah. So in terms of that, it's beautiful, and thank you for doing that. I was waiting for you. And that is the point of looking at cells that are being bound by antibody, and most of that clearance is occurring through FC-mediated reticuloendothelial clearance. When you have antibodies that either can clear by FC or by complement fixation, and Yi, as you nicely pointed out, by complement-dependent cellular cytotoxicity after Big Mac and the poking the hole in the membrane, gives you greater killing. But originally, Scott, the idea was that chimeric versus humanized, maybe that would be better. You and I know the backstory, that it was probably more stock price and financial issues and who had ownership of the drug. But we've also experienced that using Ocrevus, good drug, but we've experienced many patients that exhibit features of very, very massive histamine degranulation, which creates its own set of problems you have to be prepared for. But anyway, let's continue on, Yi.
Okay, all right. So this is the image from January 2018 after the dose of Ocrevus. I'll let it play, but essentially he had worsening of inflammatory activity, and you can see multiple areas of enhancement infratentorially in the pons, as well as scattered subcortical regions and periventricular regions bilaterally.
Yeah, I know we have Esther Malamed on the phone. Quick question. This is an unusually active perpetual motion injury machine of inflammatory damage. This patient's receiving really effective medications and yet continues to exhibit breakthroughs. So just from a practical and very parsimonious way, just to focus down, Esther, you're seeing this, you see the history. What other things might we be thinking about in terms of where do we go next to sort of rescue this gentleman who continues to exhibit a out of control burden? And is there some virtue in looking for an ictus abolisher, as in an attack? First put the attack down, put the enhancements out, and then get on to the question of maintenance. It seems as though we're on maintenance, but this gentleman continues to exhibit inflammatory and diffuse distribution of these lesions.
Yeah, so very interesting case and great presentation, Yi. When patients exhibit very active disease, we have to ask ourselves what else may be going on. So in these cases, I make sure to look systemically to make sure that there is nothing new that has developed that may be causing these patients to become active immunologically and for the brain and spinal cord to be so actively attacked by the immune system. And next, if we rule out any other metabolic issues that are causing this increased immune activity, then we consider treatments like plasma exchange to consider to bring down the immune system. We know that in diseases like NMO, plasma exchange can get rid of the antibodies, and we don't think that there are antibodies in MS. However, there is benefit to PLEX in MS patients as well when they have very active disease. And then we start to think about bigger gun therapies. So Lemtrada would be a consideration in a gentleman presenting with ongoing inflammatory concerns, as well as perhaps some of the medications that we've borrowed from the cancer world. I know, Elliot, you can talk more about methotrexate with leucovorin rescue, but essentially we would be looking at why this is happening and then ways to calm down the immune response.
Thank you for that, Esther. And the other point is that more traditionally, people might be thinking about, for example, Cytoxan, or perhaps in somebody who's really treatment recalcitrant, maybe there's a role here for Novantrone if you've exhausted other options. But I like your sequence of PLEX, because if you can get this patient's inflammation quenched on PLEX, you don't have to advance to chemo. You no longer have to check that box in terms of predilection to PML and other problems when you go on intensive therapy. But right, time is tissue. And in a patient like this, my first question would be, stepping back and before going to maintenance, is this a time for Cytoxan? Is this a time for methotrexate with leucovorin rescue, which, by the way, we have published now. It's out there. A number of my colleagues use it. It's quite extraordinary. But I'm going to let you continue.
Cyclophosphamide, think of just quickly, and he's progressing and he's getting lesions in the white matter. So we can't sort of say it's because the ocrelizumab and Rituxan don't get into the meninges, which they may or may not do, but this is deep white matter, superficial white matter. So it's the traditional, quote, places of white matter, and two drugs that are, as Scott said, eventually do the same thing, are not working. I think you have to, in the old days, this is the Howard and I used to have big fights about which patients, the slow progressives probably doesn't do good, but this is simply and if we didn't have if we were still in the platform drug era, this guy would be on cyclophosphamide because he's just totally out of control.
Yep, and he's in trouble. I just want to hear you say that, Bob. He is in trouble, and he's about to show us more trouble infratentorially in places highly relevant to contributing to his disability. Yi?
So I wanted to show you guys the spinal cord MRIs from January 2018. He also had spinal cord enhancement seen here at multiple areas along the spinal cord at the cervical medullary junction, C3-4 on the right, and also C7-T1, which you can't see too well here. So he had involvement infratentorially as well. And then just overall going back to what has happened over the course of 2018 is he continued to have clinical relapses and active MRIs throughout the year. In March of 2018, it was a severe one requiring IV steroids in addition to PLEX that was given. There was an ongoing discussion with the patient in regards to treatment options at that point. I think there was a lot of back and forth, and Lemtrada was discussed, and so was Cytoxan. and so was the possibility of stem cell transplant as well. But it didn't seem like he would have made the EDSS cutoff there. But in the end, it seems like the approach, they opted for a more safer approach in Gilenya in April of 2018.
How did he do on the Plex, Yi? First and foremost, how did in answering Esther's recommendation as a step therapy, how did the Plex go? Was it was it remission exacting?
So the Plex, clinically he improved, but slowly. But the MRIs in terms of, so the MRIs, the following MRI in April, there was some improvement in the inflammatory activity in the areas of the prior enhancing lesions, but he also developed some new enhancement as well, but less to the extent of what had developed previously.
So maybe you could show us the synthesis. I'm getting a message from Doris, who I must listen to, since yes, I answered to her. So maybe we could go to the synthesis of what eventually did we think about this? What eventually was the decision therapeutically that you went to, and just sort of the summary in terms of where are we going?
Right. So right now on Gilenya, you know, there were some issues. I don't think the Gilenya fully controlled his inflammatory activity. So he continued to have new lesions, and then he had liver toxicity due to it as well. So he's off. But given that he's continued to have an inflammation thought to be due to multiple sclerosis that's highly active, and then ruling out some of the infectious and malignant differentials that we had as well with 3 TAFs. We started him actually on Cytoxan earlier this month. He's received only 2 doses so far. So he's continuing with that, but he has not been doing clinically well overall, and he does have very limited use of his lower extremities, and now wheelchair bound at this point.
I know we need to stop. I would just you have the benefit of having folks on the phone who get body slammed all the time, so I'm just going to go first. Very brief, not more than 10 seconds. A few of the experts that are on with us, I'll start. It's not my patient, but thinking this through in terms of what I'm saying, this is an ideal patient for me for either what you're doing, Cytoxan, but if not enough, methotrexate with leucovorin rescue followed by alemtuzumab. Bob, 10 seconds.
Either one, the leucovorin or the Cytoxan, you have no comparative studies, so it's all anecdotal. I mean, they're probably both equally effective. And then I think he does need, if you can get him under control, he probably needs one of the more ultimate drugs, even though he's pretty far gone as far as any risk with infection and things like that. But he's totally out of control. So he needs Cytoxan or leucovorin rescue methotrexate, and then he needs something permanent. And permanent, I guess, would be either alemtuzumab or stem cell transplant. Even though he's not a candidate from the point of view of how severe he is from the point of what's going on in his nervous system.
Annette Okai, you're on. Annette, no right or wrong answers, but what would be your 10-second spiel for Yi?
Alemtuzumab. I don't have much experience with leucovorin or methotrexate. I'm a newcomer to that part of the treatment paradigm. So alemtuzumab, he seemed like a good candidate. And like Bob said, I would consider stem cell. I didn't think about that till he said that.
Right. And unlike the study that was done in Toronto looking at Tysabri during an ictus, either inflammatory MS or Crohn's disease, that agent, Paul O'Connor showed very nicely, you may be preventing future activity, but it doesn't clean up what's already going on. So let's just remember that what you just said, alemtuzumab at CD52 does very effective killing of B and T cells by either Fc-mediated RES clearance or by complement-dependent cellular cytotoxicity. So you're sort of getting in a sense.
Takes out monocytes as well. They have CD50.
Yep. Okay, so I think at this point,
Elliot, I'd like to make a comment. Elliot,
sure.
This is Leora Freeman. I'd like to make a comment because there's some little things that have kind of bothered me a little bit in the case. So first, there's a history of, if you can show your previous slide with the lymphopenia, and this was, so he started Tecfidera at 0.5. Is that correct?
This is the most. This is the last lab that we have
with previous neurologist.
Yeah, exactly. So this is actually on Tecfidera for over a year and a little bit.
Okay, and also, looking at the previous slide that you had with the MRI, what I find really fascinating about this case, the one with the brain, right, this one, is that it seems like the same areas are constantly getting infiltrated with blood-brain barrier leakage in the very similar area of a month. What we know from MRI is that usually the average length of a contrast-enhancing lesion is usually around 3 weeks, and most often what we see is new lesions kind of getting appearing and being contrast enhancing. But in this case, there's a lot of similar area that are chronically infiltrated. So that kind of brought to mind I had a discussion some years back. I went to visit Danny Reich at at the NIH, and I was talking with his then postdoc, Matthew Schindler, and he had kind of a case series on people with CTLA-4 deficiencies, which, considering this patient kind of has a probably long-going lymphopenia. I know you presented some of the IgG levels which were decreased, but that was during Ocrevus therapy, so I don't know how we can interpret that. But when I first kind of was looking through your case, I was thinking, okay, are we, this looks like a typical MS, but do we have an etiologic factor that may be different, some kind of primary immunodeficiency? And that led me to think about these cases that I discussed with Matthew Schindler when I went to the NIH with CTLA-4 deficiency that have, and CTLA-4 is kind of an immune checkpoint protein, and basically, the rule is that it binds to ligands on the antigen-presenting cells, and it internalizes it, and that kind of ends up with the APCs having an impaired expression of ligands, and therefore they are unable to stimulate other T cells. So it kind of
let me stop you for just 1 second, because I'm getting a message from Kathy, because I know Kathy was worried we didn't have enough things to talk about with respect to MS. Hasn't happened. So Yi, I congratulate you for bringing the most chock full. Remember that coffee, chock full of nuts? This is chock full of data. Great case, but we have a second presentation we're supposed to finish.
Yeah, just let me finish. So I just wanted to say, if this, there have been cases of MS with associated CTLA-4 deficiency. I was wondering if this patient had been worked up for a primary immunodeficiency, primary CTLA-4 deficiency, in which case he may be a good candidate for something like abatacept. So that was just a thought on thinking outside the box as to whether this guy has a typical MS. And that would also
that it's not turning off reminds me of a patient Jerry sent me years ago that was predominantly in the cerebellum, Leora, but eventually looked like this. And he was working it up. He sent it up north to Dallas. What did I think? Eventually I ended up biopsying a lesion that looks like the lower left, and it turned out to be lymphohistiocytosis, not letter C or X. It was a lymphohistiocytosis, sheets of cells, and the only thing that gained control was chemotherapy over time and intensive therapy. So exactly right. Some of these cases, they can be mimicred. That patient had less activity in the spinal cord, but it looked almost identical to what you see here. Now, but we do have to stop because I think we're way over, and I think I feel terrible that our second patient to be presented by our other fellow, we're supposed to finish at 6:15. So Kathy, you want to chime in and see, do we have time to do that presentation now, or you want to defer to a different time?
Yeah, so thanks, Elliot. So I really hate to give short shrift to the second case. I mean, don't get me wrong. I think the discussion here was outstanding and very detailed, and I'm very happy for that. Yes, it truly is. And I think that this probably deserves consideration in publication just because it is about a very complicated treatment and difficult patient. So I'm thinking we should defer, Amanda, and either make next month's a little bit longer, and everyone knows that ahead of time so people can prepare rather than kind of ask people to stay later tonight. or have a second, have an
everybody,
additional
we do have
session,
everybody
and we
here
can talk
tonight.
offline.
Maybe we can see, knowing that these are archived and the fellow did take the time to present it, maybe we should just give it a run. And if we're running 10 minutes over, maybe this is not going to be as complicated as the first case. I just feel that maybe we should give that a chance, because we may not have, have fellows, we don't have the slots. So I'm wondering, and we could get into even part 2 of this. I think Leora is bringing up other issues like checkpoint issues. That was the Nobel Prize this year from CTLA-4 and discovery of PD-1. But I think we should give Amanda the opportunity to take us through our case. And I don't want to short shrift in terms of the comments, but if we run a little over, we run. It is on the archive, so people will have access to it.
All right.
Scott, what's your take?
We'll move forward.
Perhaps we should ask Amanda how she feels about
Yeah, I would.
Yes.
That would be
Good idea.
Yes.
I'm certainly okay to present tonight. That works out fine with me if it works out well with everyone else.
Okay.
You've taken the time to do this. I think we should stop this presentation and go on. And by the way, Amanda, don't think about anybody else who chimed in. Elliot Froman gets all the blame. As the chair taking prerogative, I get the blame for the time. I want to see your presentation. So let's go ahead and make the shift.
Before you guys start talking.
Can we boot up those other slides?
All right.
I'm
Thanks,
sorry, yeah.
everyone.
1 second.
Great job, Yi.
Thank you.
You got us all hot and bothered.
Sorry about that, but thank you everyone for your input on everything, and I'll take everything into consideration.
Would be great to have follow-up, especially if we end up going to a paper like Kathy suggests, and I think she's probably right.
Okay.
All right, Amanda.
Can everyone see my screen?
Yes.
Yes, we can.
Okay, wonderful. Well, I'm Amanda Thuringer. I am the fellow at the University of Kansas Medical Center, and I wanted to share with you tonight a seemingly simple case. I'd hate to say that on such a very interesting forum with so much discussion on the first case, but what was most interesting to me was the challenges from a management perspective. So with that, I wanted to start. Maybe. Okay, so we had a 31-year-old right-handed female who presented with a diagnosis of relapsing remitting multiple sclerosis, and she presented for a second opinion on disease-modifying therapy selection. As far as her clinical history goes, in 2012, she had an episode of progressive numbness and tingling in her legs that spread from the right side to the left side and eventually involved her entire legs. This was presumed at the time due to be peripheral in nature, and it resolved in about 3 months' time. Then next, she had involvement of her right arm and leg. Again, this lasts for a few months and then remitted. She first saw a neurologist in June of 2017, so several years into her course. And she was worked up and eventually diagnosed with MS, and she began Copaxone in September of 2017. And then she had another relapse where she had left chest numbness and left leg numbness. And this point, when we saw her in January of 2019, had improved but not completely gone away. And so more about her history. Her history is pretty benign. She's on Copaxone, as I mentioned, as well as an oral contraceptive pill. She's married. Social history is otherwise benign, apart from the fact that her desire to get pregnant this summer. Family history, she has an aunt with MS, but otherwise not too contributory. On exam, her exam also was fairly benign. She'd had basically a normal exam apart from slightly asymmetric hyperreflexia and decreased vibration in her lower extremities. These are quick snapshots of her brain. I have only a few pictures to share with you tonight, and I just wanted to highlight the areas that had changed over time. So we've got her January 2018 pictures on the left, and you can see she has the interval development of a small, non-enhancing midbrain lesion on the left side. In addition, higher up, She'd also had the development of a small periventricular lesion that on the post-contrast imaging, it does enhance. And I have a second picture higher up that kind of more defines that, because in this left-sided picture, you could speculate or wonder, could this be a blood vessel? But indeed, on the axials higher up and the coronals, it looks like it's actually a lesion and it does enhance. And in terms of her overall burden of disease, it's quite mild. She'd had some other imaging sequences that I've excluded that have other periventricular lesions, but again, fairly mild burden of disease. In terms of her cervical spine imaging, this was also done, comparisons for the same time course. She has, a slightly more accentuated area here in about the C6 area as compared to on the leftward images, the older lesions, so a new lesion there that did not enhance with contrast. And hard to perhaps see in this forum, but she does have this subtle area of increased hyperintensity that was patchy and kind of ill-defined on the pictures, questionable area of a new lesion as well. And then last but not least, the imaging of her T-spine done in the same time course for comparison's sake identified a new contrast-enhancing lesion in her middle T-spine. So I wanted to share with you the rest of her workup. She'd had a CSF historically before she came to us that showed positive inflammatory markers, a negative aquaporin-4 antibody, and the infectious screening that I have here on the screen. So with that, I wanted to pose the question to the people on the phone on what treatment would you recommend this young woman? And then specifically, she really wants to get pregnant this summer, and that's a big deal to her. And so would that change your recommendations? Which drug would you pick, and what time would you recommend to this young woman?
I don't think we've heard from Ethan Meltzer yet this evening, our terrific fellow here inaugural fellow here at Dell. Ethan, there's no right or wrong answers, but hearing the story, counterbalance between pregnancy, control of the disease, have supra and infratentorial lesions. What do you think?
I think that I am watching my baby walk up the stairs, so if I have to go, that's why. But I think that there's a few things in terms of counseling for her. Obviously, we all know that MS is a protective state, but then we also know that women do better during the pregnancy if they haven't had relapses within the prior year. And so I think it is important to kind of be realistic and want to balance, obviously, the need for family planning with also the need to try and make sure that she doesn't have any sort of relapse either prior to conception, because we don't know how long that will take, or during the pregnancy, when it might be a little bit harder to be aggressive with treatment for relapses. So I think that's the first thing. And then I think it really comes down to an area where, obviously I think we're going to review some data with it, but that we're fairly limited in terms of, actual good trials at looking at, which medications are safer. And I think everybody knows that Copaxone has the best pregnancy data, but that doesn't militate against the use of other medications such as Tysabri or other things that may be relatively safe, at least leading up to conception.
I think that's a great point. And the concern I have about this patient, Amanda, is that young or not, or how she recovers from activity, she does have brainstem tegmentum involvement, patchy multifocal spinal cord, lesions up top, activity not that long ago. And while Copaxone may be the safest, we also know people who often do the best with Copaxone may take 4 to 6 months before the drug's fully operative. And so one of the things that Ethan mentions about Tysabri is that this is a rapidly acting agent on reducing attacks and lesions, effect on progression. She's younger. We've had many patients get pregnant on Tysabri. It's not as good as Copaxone from that standpoint, but I think that it's a reasonable counterbalance, hearing what Ethan also said about we don't know how long it takes to become pregnant. Even if folks have had previous pregnancies that occurred rapidly, that doesn't argue against a delayed period where your patient, the first patient, not the one to be named later, but your first patient is at risk. So I think the idea of using something potent that can keep the patient in control until they're pregnant, I would think Tysabri would be a great choice. I'm always wanting to discuss the prospect of thinking about Lemtrada as a way to delete, remove the heritage, stabilization, but we all know that takes time and a long period of follow-up.
The trouble with Lemtrada, this is Bob, and I'm going to have to bail out in a few minutes, but the trouble with Lemtrada is that the T cells may take 14 months to come back.
That's right.
So somebody put a comment up quickly, and it may have disappeared, but even though the FDA says, you know, even Copaxone is no better than a B, ocrelizumab, somebody mentioned in passing. So if you did that now, and you wait till the ocrelizumab is out of the system, so baby doesn't get ocrelizumab, baby doesn't need the B cells from mommy at this point, presumably. I want to see what Scott thinks about this. So you could do that, say 3 to 4 months, and then try to get pregnant, and the baby doesn't get the ocrelizumab. The baby doesn't, mommy's B cells are gone, and these things last a long time. We've been looking at it, and some of these, I have a patient, somebody gave ocrelizumab for I don't know what reason, and he's about 9 months after his last infusion, and he still has no B cells, at least in the peripheral blood. So these things last a long time. One dose of that, if she gets pregnant quickly, may be the way to do it. And whoever put that up, I think that's, you know, all of these things are off FDA guidelines. I don't even suggest Copaxone.
This is Annette Elliott. Just to add on to that, with the CD20 therapies, Maria Hutchins have some data out there using rituximab in these patients prior to them getting pregnant. So the same concept will hold true for rituximab, and the data is out there to support that you give it to these patients prior to them trying to get pregnant. And we know the half-life is about 25 days or so, and the B cells remain low, like Bob said, and you can have them try to get pregnant at that time. So that's another way to approach this patient, especially if she has both supra and inferior disease.
Problem with the Tysabri, Elliott, if you gave it just before rather than all the way through, I don't think with that active an MRI scan, you want to see her rebound while she's pregnant.
Oh, no, not at all. Not at all. And I wouldn't give it just once. I'd do it. If she becomes pregnant, as Ethan says, they do quite well through pregnancy. But patients I've had get pregnant on Tysabri, I've not seen during pregnancy that an iris or a rebound, and hardly.
If you wanted to do it, you would induce a quote remission and then stop. That wouldn't be you. If you committed to the Tysabri, you'd have to commit to it. I agree.
Well, there's also the JERMA data from Christine Helwig that shows the use of Tysabri during pregnancy for this. So after a certain time, you can continue to dose through pregnancy. So there is data out there that show that it has been done before.
Yeah, and we of course have the most experience with that agent than any other, and knowing that we're big fans of the CD20 drugs, but we also know that there are inherent risks of using those for time as well, including not just infection, but even PML, which can have a Tysabri as well. But so the question is really going to be, what do Amanda feel most comfortable in terms of her exposure, not knowing how long it's going to take to become pregnant? You could write on a prescription pad, get pregnant now, rather than waiting till summer or some future date, but that doesn't mean she's going to become pregnant. So I think the key is you have to have something on board which is reliable, you can count on, and when the pregnancy occurs, we don't have, FDA giving us a green light, but we have an active patient that I believe we need to treat, and her ability to mother this child will be at least somewhat contingent upon the activity and the consequences of that activity of MS. So I think that's partly why you're hearing people talk not about orals or injections. You're hearing us talking really about higher court of appeal with either Tysabri, CD20 drugs, and Lemtrada maybe is a consideration for much later, but definitely not off the table. But the beauty of Tysabri and Ocrevus is that you are going to get rapid effects in terms of the onset of the efficacy associated with it as a DMT. And that's going to take time with Copaxone, and the patient may not be a Copaxone responder. So, you gotta take all that into consideration. So additional slides or comments or questions that you have, Amanda?
No, that was a great discussion, and it generated a lot of interesting ideas. We had a lot of the same thoughts in the approach to our patient, and proposed to her the idea of giving her immune system a jump start with one of the high efficacy agents, and we thought about using Ocrevus, thinking about the more long-lasting effects on the immune system. Though it's relatively new, we may not know everything about what happens in pregnancy with Ocrevus, but we thought that that would be reasonable, and that was one of our recommendations or options we proposed to the patient. And then the other was the thought of continuing to use Copaxone up until pregnancy with the possibility of using it through pregnancy, but we were thinking about stopping it during pregnancy and then allow her pregnancy to run its course and her immune system to have some protection from an MS standpoint based on information we'll talk a little bit about from an MS standpoint.
Yeah, remind me about on Copaxone, how much activity has she had on the drug?
Sure.
Has she had it?
And she had
yeah, so the other
she
question,
has active MRIs, and so she certainly has radiographic activity, which concerned us. And pregnancy
we
was
might
off
have
the
to go
table,
back to
we
the
would
dark to the dark ages if you did the more intensive therapies and your point about using Copaxone. Then the question is, do we go back, Bob, if Bob's still on the phone, in the old days not that long ago, we might have said, well, patient's very risk adverse. What about the idea of Copaxone in combination pulse month steroids, or patient getting look, if it's good enough for postpartum delivery to 6 months.
Yeah, I mean, one possibility depends on what the patient, and I'm going to bail out right now, but yeah, I mean, Copaxone with some pulse steroids until the beginning of the, not big stuff, 3 to 5 days, maybe just 1 day a month. And then when you get to the last 3 months, that's when your estriol, alpha-fetoprotein, cortisone, and everything else that probably reduces relapses kicks in, and that's when you don't need to use the steroids. And if she's already on the Copaxone, you might as well just leave it. I've had a couple of patients who've insisted on staying on the Copaxone who were as mild as this young lady, but to be fair, did not have as active an MRI scan. So that was a much easier choice for her and for me, and the patient happens to be a nurse. So it was easy because the MR didn't look like this.
Okay, Amanda?
I'm going to bail out right now. So this has been great. Thanks.
So we still have till 6:15, so we have time.
Okay, wonderful. So I guess I wanted to talk more about what we know about MS and pregnancy. And so with that, we've kind of already touched on a lot of these topics, but in kind of putting this complicated decision making together, wanted to go over some of the key issues and why we would do certain things. And so the idea to not use a disease-modifying therapy specifically during pregnancy, around pregnancy, or the decision to use one would be the idea of reducing this woman's potential for disability. And that needs to be balanced with adverse risks of the medication, as well as pregnancy complications due to the treatment itself, as well as the possibility of ill effects to baby. And then the idea of the camp that's on treatment, either prior to pregnancy or during pregnancy, with the idea that, are you more likely to be protective of the growing fetus and future baby versus the potential risks of increased disability to the mother and possible pregnancy complications that could come from MS. So I guess I generated some of these questions as I was thinking about this, and I hope to answer these as we went about this talk and try to weigh all of these decisions when we focus on our patient and what the specific patient in front of us and what types of factors would weigh into this decision. So what we know about relapse rate in pregnancy is based on a study back in 1998, a European prospective study called PRIMS, and they looked at 254 women, nearly all with relapsing remitting MS, and they were evaluated for 33 months total. And so with that, they showed that the annualized relapse rate during pregnancy decreased with a nadir in the 3rd trimester, and then after pregnancy rebounded to a rate higher than what was their pre-pregnancy risk of relapse, and then settled out subsequently. And follow-up studies to this have identified a similar trend, though haven't had as robust of a rebound after pregnancy. But certainly that would be an issue worth exploring if you were considering giving recommendations for a woman that wanted to become pregnant. Before this, it's my understanding that physicians and neurologists in general would recommend patients with MS to avoid pregnancy in general. And so this is an interesting paradigm shift.
And that's a great point, because we do know from, yeah, go ahead.
Sorry, this is David Lapidus. Amanda, are you familiar with the, I think it was an abstract even that just came out from Annette Langer Gould regarding the rebound data out of Kaiser that, again, as you mentioned, suggested that there may not be a rebound postpartum.
Yes, I saw that as I was preparing and reviewing for my presentation.
Yeah, and Amanda, those were mostly male neurologists giving women these prescriptions about don't go out in the sun, don't get pregnant, don't stress out, to eliminate stress. All stress would be very stressful. But the Ontario data from Weinshanker Natural History in those days show that the multip do better for latency to progression if they have it. So certainly more precocious disability in who are null tips who have not had pregnancies. And by the way, that is not explained by differential courses very early. These are younger women. So you don't make the argument, they didn't have children because they couldn't raise them, and those who did better and could have more children. That was not the confounder, because it was much earlier in the disease course, earlier than when most Caucasian women would be accruing disability. It really does appear that pregnancies and multiple pregnancies are favorable. Yeah.
I think this is Annette Elliott. I think one thing when I saw Annette Langer poster this morning was one thing I do agree with is that, this study was done before we had all these other medications that show higher efficacy in women, and it was mostly this was the injectables. So it will be interesting to find out, and update this data, what happens when we stabilize people with high efficacy medication prior to pregnancy or even through pregnancy, and what their relapse rate are over time, postpartum and during breastfeeding.
It's a really great point, because if the data suggests that your activity in the preceding 6, 12, or 18 months before pregnancy is a predictor, how are we going to resolve that when the drugs we're using are more effective and intensive? And how do we look at postpartum activity versus pre when we've had patients for a long time before pregnancy? That's a great blessing, but it may be very, very difficult to look at that in the way that it was looked at in the natural history studies. And my hope and prayer would be that these high intensity agents, and then taken over by pregnancy, and especially the 3rd trimester, maybe we'll see very little, and there'll be a carryover effect in terms of how they do. But I'm going to bet there'll be differences between which of the intensive drugs people are using going into pregnancy may have that influence on what happens after. Okay, Amanda?
All right. Well, some of these topics have already been discussed, but basically wanted to review some of the factors that could potentially predict during pregnancy and also postpartum relapse. And so, as Dr. Froman has already mentioned, low preconception relapse rate seems to predict a decrease in relapse during pregnancy, as well as a study that looked at preconception DMT use when it was used within a 2-year period prior to conceiving. It was shown to have a decreased rate of relapse during pregnancy. There are also some interesting data about the use of steroids that was already mentioned as a possible management tool. And different studies have looked at different kind of methods of giving them, like 1 gram every 6 months, found to be helpful as they compared to historical control groups, as well as a group that gave 1 gram of steroids at the time of delivery and found effect on decreased risk of relapse. And then last but not least, breastfeeding. Breastfeeding has been found with some conflicting data that in one study, the first study that I have there, showed that there were beneficial effects, and then with a larger cohort group of almost 300 patients showed the opposite or a neutral effect. And so I think the jury's still out on that one.
Do you want to make any comment, I see steroids, but about the Israeli Anat Acheron? Many of us postpartum are still, and I continue to do so. It's been very effective, at least in our practice, in terms of using IVIG, which we give in a much lower dose, either 0.2 to 0.4 gram per kilogram for a single day, usually for us at week 1, 7, and 13. I know the original Israeli study was 0, 6, and 12. I moved it out a bit only because many of these people may be dehydrated, you can give them a headache postpartum, they may have had an episiotomy. So we usually will wait a week. The benefit of doing it at 0 is you have them in the hospital, you can get away with it easier than doing the pre-authorization. But at the very low levels we're giving, we really have had very little difficulty getting approved. But any comment about steroids versus IVIG?
When I was looking at the data, it sounded like there was more data to support the use of steroids, with IVIG having a few trials that didn't show benefit, but I was interested to hear that IVIG was used around this time and some had some success with that treatment modality. So I think it's still an interesting idea.
Remember, the original Anat Acheron study from Israel was in women who were pregnant currently, but had a prior pregnancy with a postpartum exacerbation. So it was already enriched for people who at least had shown a predilection previously. And then it's a small study. This group of patients were now pregnant and got IVIG at delivery 6 and 12. And none of the patients in that cohort had an exacerbation in the defined period of postpartum, which she defined as 0 to 6 months. Obviously didn't cure their MS, but they did not have exacerbations after that time. So I don't know if anybody else has a different experience. Leora, you were trained in France and you've been in Houston for a while, so your experience has been on both sides of the ocean. What have you seen, and what do you do in terms of postpartum between nothing, steroids, IVIG, breastfeeding and waiting for N? But what's your use about postpartum strategies to prevent postpartum events, knowing that there is this corresponding escalated risk of attack after we complete that very beneficial 3rd trimester? Oh, did Leora jump off? Okay, well, maybe Esther. Esther, you're still on?
I'm here.
Yeah, what's your take?
So in terms of pre-pregnancy, usually discuss all of the options that were brought up in terms of Copaxone versus...
I was talking about delivery, though, in terms of prevention of postpartum attacks is what I was referring to.
So again, same thing around the time of delivery, we discuss patient options. I meet with patients pretty frequently during their pregnancy, and we have an ongoing discussion about the options and whether they're going to breastfeed versus not breastfeed. If they are, there's data to support breastfeeding as a protective measure against relapses, but women have to choose to breastfeed consistently. And if that doesn't become an option for the patient, then of course we can go to any of the therapies that would be available for any other patient at that time. If they do choose to breastfeed, then the data is mixed. Copaxone is still a possibility. If they're active, then we discuss how many attacks would we tolerate. Are we okay with 1 attack? Usually I'm not okay with more than 1 attack, and if the first one is a devastating attack, then we stop breastfeeding and move on to the appropriate therapy at that time. IVIG is certainly a consideration in some women, so we really keep the dialogue open around the time as pregnancy approaches and jointly agree on what the options would be postpartum.
Annette, you're still on the phone with us. What is your, again, there's no right or wrong answer. What generally are you recommending to your MS patients in terms of prevention of postpartum attacks?
Postpartum attacks, I usually use steroids just because it's easier and not a lot of headache with like the IVIG getting approval. So I do dose them while they're in the hospital, and then depending on their breastfeeding preference, we decide if we should do pulse steroids until they are ready to go back on therapy if that person is not a Copaxone candidate. With Copaxone, I usually have them continue while they breastfeed because most of it is broken down before it even passes through the milk. But usually I use steroids because it's easier for the patients during the postpartum period, and then decide what we're going to do.
Yeah. Any concerns about postpartum depression being exacerbated by steroids administered at delivery?
I haven't seen that with most of my patients, so that hasn't been an issue for me.
Yeah. Fabulous. Could go the other way too. They could be euphoric and they'll start bringing you food, clean your house and do everything else. Right. You get that. Ethan, are you still on the phone? You're also now a parent. So thinking about it from the standpoint of if it was in your family, you're a parent, you have a child, and you're taking care of patients, what would be your approach in terms of discussion and then to intervene or not to intervene to prevent postpartum exacerbations?
Yeah, I mean, I think that either steroids or IVIG are good options, and especially in the postpartum period, depending on maybe some of that depends on the support that the mom has at home, if there's going to be family who's around, and because both therapies do have some evidence showing benefit, and so really it's going to be the one where you're not adding necessarily kind of unneeded stress to the mom, but also wanting to make sure that you prevent relapses, and so still wanting to kind of be aggressive, and because a relapse during this period a few months after delivery could be fairly devastating in terms of if somebody who is about to go back to work has already missed a lot of time, or now doesn't have much support at home and then won't really be able to care for the baby.
Those are really great points and very important points. Very, very important. And I think as most have commented on with respect to this, especially Esther, this issue of more frequent visits before delivery and preparing and discussing options, and people can always change their mind, but I think there's no substitution for the dialogue and preparing, and let people know, because things can happen postpartum, it's not an absolute thing. You don't want people to be freaked out, but also let them know that there are options that have been used for a very long time and are really, by and large, overall very safe. As Annette points out about steroids postpartum, we know postpartum depression is a real thing, unless you're Tom Cruise, although I don't know how many children he's actually birthed, but it is a real phenomenon. You just want to make sure that we know about the support at home and the context in which we're bringing this new life into the world that we're responsible for, and doesn't change the fact that the mom has MS. So your point is very well taken that even though the rate is not tremendous, and we know from the Israeli study, those attacks that do occur often are sensory and don't contribute in a major way to impacting disability, during the case of that event can be very unraveling and emotionally very upsetting. And of course, some of them can involve things other than just sensory pathways. So you always have to individualize these decisions, which is why I love Esther's approach of we should be meeting more frequently, having discussions and planning, and they know you're there on the team. So if there's a problem postpartum, they're not going through it alone or at home with folks who want to be supportive, but they're not experts on the disease. And everybody on this call is in your own way, and there are a lot of options. So Amanda, any other further comments you have before we conclude? I know we're running a little bit over, but this is a very important, timely discussion. It's the first one we've had focused on this issue, which is huge, pregnancy and MS, since at least Teresa and I took over the management of the webinar. So I want to thank you for bringing it. It's as important as it ever was. And just the dates on these papers illustrate 2004, 2011. We have a lot more to do and to learn. And the point was made that a lot of these studies were done before we had all kinds of things, more advanced MRI, more intensive therapies, and of course, a lot more data. So anything else that you have to share with us before we call it a night?
Oh, I have several more slides, but I think in the essence of time, maybe we can call it a night if everyone is tired and wants to call it a night.
Well, how about a synthesis of those last few slides? What were you going to show us? Anybody who needs to get off can get off. I'm happy to stay and look at what you have. You took the time to prepare it.
Sure. I think we've already kind of touched upon some of these topics, so we'll skip that. I was interested to learn that there is an increased risk of cleft palate in the first trimester as we think about potential exposures and risks to baby. The rest of these I think we can skip for now. In women with MS, they typically want to know, well, what does this look like for me getting birth? And on average, most outcomes are similar to people that don't have MS, but there is a higher rate of C-section and the possibility of a low birth weight. And then I wanted to skip way ahead, and I'll just show you the summary slide of mine that I put together. And so I just wanted to, I guess I put this together to kind of look at all of the different medications, and the green, yellow, and red are by no means my, an official recommendation from some higher authority, but this is just how I thought about these things. And so when considering whether or not to continue on a medication to conception, through pregnancy, and after, I looked through the literature and came up with these things. And so for the recommendations to hold before conception on the very last list, these were basically from data from the package inserts in general practice based on expert recommendations. And then the rest of it, I think, is pretty self-explanatory. And so in general, it seems like our injectables are often considered the most safe, or at least a consideration to take during pregnancy. The pills have a variety of effects, including the risk of fetal loss and teratogenic effects, especially with teriflunomide. And then last but not least, our infusions are, on average, our newer agents, with certainly there's still a lot to learn about these, especially in the use during pregnancy, but just going with the monoclonal antibodies, they don't cross the placenta, at least until the first trimester, if not later, based on their mechanism of transport through the placenta. In animal studies, especially at supertherapeutic doses, which they tend to do for all except for teriflunomide, there are some risks. However, in human studies, those have not necessarily been identified so far, though case reports are limited. And specifically, the question was raised on if these medications are safe during pregnancy or breastfeeding, and ultimately we don't know, but based on their size and their bioavailability, they're probably not necessarily being exposed to babies, since they are ingesting the monoclonal antibody and would be digested in the baby's digestive system. And so ultimately, probably still more to learn, but could be useful in kind of future research.
And in terms of your issues as it relates to during pregnancy, I think for most of us, obviously, once a woman becomes pregnant, the idea is to try to discontinue the medication and let pregnancy take over. Where the issue is between the time of being on treatment, trying to become pregnant, by the time a woman identifies the pregnancy, oftentimes we're already well into or even beyond the embryologic period. Most of us would be stopping these drugs after we identify pregnancy. The issue, I think, which is most compelling, is the time during women are trying to become pregnant and are still on these treatments. And so I think it's important to underscore that once women become pregnant, the vast majority of our patients were, of course, attempting to take them off unless they continue to be active, which I find to be not very common, but can occur for sure.
Mm-hmm. Certainly. Yep, I'm in agreement with that.
Okay. Any other final comments before we stop? I know we've gone over, but I personally am very, very delighted that you had a chance to get this in. You worked very hard on it. It was great. Here are the conclusions. Here are your conclusions.
Oh, here are my
great
conclusions.
job, Amanda.
Thank you so much.
I wanted to also just bring up the point that as patients are trying to get pregnant, and as we've underlined, that it's hard to know when they're going to be pregnant, it may be a good strategy to have patients work with fertility specialists to discuss with them upfront ways to monitor for their pregnancy, getting pregnancy kits, and also underlying the fact that a lot of our young MS patients may be having sexual dysfunction, and that may interfere with getting pregnant. And so doing those evaluations up front and referring patients as needed to specialists to further help them in that process of becoming pregnant is really, really critical for the success of their treatment during that stage and as they transition to pregnancy and beyond.
Those are really great comments, Esther. They're all great. I particularly like your first one, which is not to make them crazy, but to have a tighter, more high precision handle on knowing when pregnancy is actually established. And that would be good in order to know earlier rather than later for the reasons we just brought up in terms of continuing therapy. So there's not a perfect strategy, but knowing sooner rather than later would be a great thing. I think we've probably all seen women who have had erratic, irregular periods. By the time there was a declaration of pregnancy, they might have been 3 months and sometimes longer into it. So I think your comment about working with professionals and understanding how we can monitor the establishment of pregnancy more easily and earlier should have great dividends in terms of safety and letting the benefits of pregnancy on MS take over and having the opportunity to have cessation of the primary disease modifying therapies, particularly as we're using more intensive ones. So Amanda, I want to thank you for being such a great sport. This is a terrific talk and very important one. And if there are no other comments or questions, I think we'll go ahead and conclude. Kathy or Doris, do you have any final housekeeping?
Kathy.
What's that?
This is Kathy, and I really want to just thank Amanda. Can you hear me? And Amanda, that was a really very nice case, and I particularly liked the chart, which I think could be very useful to providers to have something all in kind of in one place. And I'd also like to recommend that everyone take a listen to the current topics webinar that Doris put in the chat, but we can also send to everybody, as it reinforces many of the points that Amanda and others made today, and also presents a bit of other evidence that people may find helpful in this topic. So thank you all very much. Doris, anything that you might want to add?
Nope, that's it.
Kathy, where is that? Where is that? What meeting is that from, or what webinar is that from?
Yeah, so the current topics, which is the VA MS Society collaboration, it occurred today. It's archived. We'll send out the link to that archived webinar to everyone that was on the call and all the rest of the faculty. I think it's quite useful, and like I said, it reinforces a lot of what Amanda said tonight.
Okay, that's fabulous. Wonderful. Okay, guys, for all of you guys who stuck in there with us, I think it was a great thing. And I'm happy you had a chance to do that tonight. This was really important and it's timely, and definitely did not want to take the chance of delaying and not fitting in, knowing how you had prepared for it. So it was really, really lovely. I really enjoyed it. And thank you for sticking in with us.
All right, thank you.
And with that, I think I'll say goodnight and hope to hear from all of you in another month at our next webinar.
All right, good night.
Terrific.
All right,
good night, everyone.
Thanks very much. Bye-bye.